Good afternoon, everyone. I welcome all for today's special distance learning seminar. And topic for today is Intensified TB case finding at HIV care settings in India, opportunities and challenges. And speaker is Dr. Rajesh D. Deshmukh. He is working as the national consultant at WHO and program officer for HIV-TB at National AIDS Control Organization and Ministry of Health and Family Welfare, New Delhi. He has completed his post-graduation in public health from SRTR Medical College in Maharashtra and has over 15 years of experience in working as a public health specialist in the states of Uttar Pradesh, Gujarat and Maharashtra. He has traveled extensively across the country for evaluation and program appraisal with national and international teams. He has worked as national trainer for drug-resistant TB, TB-HIV and airborne infection control. He has represented the country in several international conferences and published articles in national and international channels. Thank you for accepting our invitation, sir. Now I'm handing over the session to Dr. Rajesh Deshmukh. Thank you.
Thank you very much. And good afternoon all. Welcome to this distance learning seminar. I hope you are able to hear me clearly. In the past session, we had discussed about the third I, that means the infection control among the three I's in intensified case finding, infection control and the isoniazid preventive therapy. So today basically we are going to discuss on not only the intensified TB case finding but also what are the challenges and opportunities which are coming up for the program. I will try to be basic on this presentation because we have a broader audience today. We have private sector participants, NGO participants, a few of our colleagues from CSCs have also joined. So my presentation will be basics including the newer updates on this intensified TB case finding. I will prefer to take all the questions post session to maintain the flow of the presentation. If you see this scenario, you can see that India is ranking third among the high burden people living with HIV estimated cases, and you can see that South Africa has the highest number of cases. If you see the latest global TB report, you can see this plot very clearly signifying the estimated TB incidence globally. The brightest spot, if you see the Southeast Asian region is having the highest number of cases, and you can see the red dots where you can see prominently India, China, and there are several countries like South Africa having a very high burden of estimated TB incidence. You can understand that all the BRIC countries, that is Brazil, Russia, India, China and South Africa, these contribute to almost 50% of the TB burden. That's why India has strengthened its effort to TB control and extensively TB and HIV also. When it comes to the HIV prevalence, as per the global report 2014, you can find that the global epicenter for HIV is of course South Africa, and Nigeria is also listing second. India, although in absolute number is ranking third, you will see that among the TB patients and TB HIV co-infected patients, India ranks second among the 41 high burden countries globally. So even if you see that the prevalence in India is ranging from 15 to 19, there are a lot of pockets within India where the prevalence is very high and is similar to South African settings. In case of HIV, globally you can see that there is a huge progress, and globally the new infections of HIV has declined by 33%, and its related deaths have reduced to 30% in the last few years. And India has contributed to that success, where the death rates have significantly reduced to 35% in the last 6 years. Majority of it is attributed to our excellent ART scale-up program, and also the new infection have reduced to 50% over the period of time. So overall, the India's success story in declining TB is also confirmed from the recent HSS information and data. But now if you see micro-analysis of all those regional variations within India and the trends which are coming up, you can see that although the decline is seen in northeast and south, but then there are certain pockets which are emerging as new pockets, specifically in North India and Central, where the HIV among ANC prevalence among is increasing. And if you see this pie diagram, you can easily notice that almost 57% contribution is now coming from those areas which were low prevalent states earlier, specifically in North India, like Punjab and various other states like Delhi have shown different trends and different epidemic scenario. Those states which had initially high prevalence are contributing to 31%. So now the challenge is to focus on the newer areas and pockets where the prevalence is high. So even the latest HSS estimations confirm all these things, and now it mandates that we will have to focus not only in the high prevalent states, earlier 6 high burden states, but also in those areas which are coming as newer pockets in India. These graphs clearly suggest how the epidemic scenario had changed over the period of time, and if you see the dark brown and red patches, you can see the distribution was initially concentrated in few southern states, but now it has spread out to the other parts of the country, and this is attributed to a lot of industrial development over the period of time, which increases the migration of population and thereby increases the vulnerability in the newer pockets where even the spouse are getting infected. So basically this is emerging as a very big problem in purview of HIV and TB as well, because you know that in northern states the prevalence and if you see the ARTI estimates, the northern states have high burden of TB. So this HIV epidemic in those areas or certain pockets may flare up the situation, and that's why we have to concentrate not only on particular areas but also on those areas which are emerging pockets in India. This is challenging in today's situation because the infrastructure in those areas and the testing facilities as well as the decentralization of our centers, treatment centers, is needs a more revamping in those areas. And as you see, the distribution of the centers and distribution of the testing facilities is varying in these areas based on the earlier priorities. So now it is more challenging to address these situations, specifically in response to HIV and TB in northern region. This is more relevant when it comes to TB mortality among HIV positive people. So you know that the TB is most common opportunistic infection and leading cause of death among people living with HIV. So now with the newer forms of TB like the drug resistant TB and the extensive drug resistant TB, you have more challenges in these areas, and TB addressing these issues is very critical for the program now. In India, if you see this diagram, you can see that there are several pockets in India which are showing high death rates, and therefore we will have to focus our interventions in these areas and revise our strategies when it comes to diagnosis of TB, as well as then intensifying our efforts in newer pockets. So you can see that 86% of the HIV-TB deaths in India are coming from some specific regions, and there are certain pockets in India where the death rates are on the South African trajectory. So we will have to be very cautious in the next few years and increase our TB HIV efforts to address this dual burden. Globally also there is a huge interventions going on to end TB, and WHO has come up recently with the end TB strategy. There are a lot of components which include integrated patient-centered care and prevention. There is a need of bold policies and supportive system, specifically social protection and poverty alleviation and other actions. And intensifying research and innovation is a critical area of the NTB strategy. The most important among this is collaborative TB and HIV activities, and then management of comorbidities. So in this line, to end the TB, we have to intensify our collaborative TB HIV activities and manage the comorbidities. Specifically in India, we are very strong on TB HIV collaborative activities because we started early. In 2001, the basic TB HIV activities initially started in 6 high burden states, and later on they were scaled up in the country. The 2012 June saw the nationwide coverage of TB and HIV services. Meanwhile, there were some national policy and frameworks developed, and recently this has been updated in 2012, where the government of India has defined all its policies related to TB and HIV and the newer strategies which are adopted. WHO in 2012 came out with policy and guidelines for the national program and the other stakeholders, where it focused on certain critical key areas like establishing and strengthening the mechanisms and reducing the burden in people living with HIV. These three I's include the intensifying TB case finding, and that's why we are going to focus on ICF activities, specifically through the HIV settings, and intensify our efforts in these directions. The National Framework for TB and HIV in 2013 clearly specifies 3 I's. The first is intensified case finding, the second is isoniazid preventive therapy, and third is infection control in HIV care settings. So these 3 I's for intensified TB case finding is most important, and specifically screening of symptoms and signs of TB, not only in the general settings but also in specific settings which are dealing with people living with HIV and those who are attending the different healthcare settings. You all know this is very much required because TB is most common opportunistic infection in HIV, and if we don't diagnose TB early, it will lead to increase in transmission of TB. As you know, basically one TB positive can spread to others almost 10 to 15 as estimated. So it is very important to reduce the transmission, detect TB early, and delay in diagnosis can lead to increase in mortality among different groups. So it is critical to intensify TB case finding in all these settings. It includes not only at ICTCs but also facility integrated ICTCs and ART centers, link ART centers, and targeted intervention projects. It also includes now community settings like the care support centers and the private settings where we have TB and HIV collaborative activities. So therefore we are now intensifying these efforts in all these settings based on the 4 symptom screening. So what is this 4 symptom screening? WHO and various other studies which were conducted have shown that all people living with HIV should be screened regularly for TB using a clinical symptom based algorithm which consists of current cough, fever, weight loss and night sweats. So any of these symptoms at any time of initial presentation or at every visit to the health facility or contact with the healthcare provider should be ascertained. Similarly, in children living with HIV who have any of these symptoms and poor weight gain, contact with a positive with a TB case, and those who are malnourished and other high risk, actually those who are immunocompromised can also be screened with this. So basically this will give a negative predictive value. This has a very good significance when it comes to scientific reason of all those things, and it has negative predictive value of almost 97.7%. So this 4 symptom screening is most critical to identify the presumptive TB case. These days TB suspects are referred to presumptive TB case. So to simplify this screening and to ascertain that and to ensure at all these settings, specifically at the counselor level, we have developed an integrated counseling tool for HIV and TB. We know that there are several counselors from different departments working within the district setup, and that's why this is an integrated counseling tool where all the counselors, whether he is from ICTC or ART, from STI or PPT, CT, and even the programs like non-communicable disease programs, DRTB counselors also, they can use this integrated counseling tool on TB HIV. This has very relevant 10 important key points which identify and which are helpful for the counselor to identify the case early and counsel it in a quality, counsel these cases in a quality manner. So we have devised certain newer models in this one, and we advise that this should be promoted in each and every level. Specifically the counselors can use this extensively so that the cases are not missed. At the ART center we have a very good mechanism of 4 symptom screening and fast tracking the patients who are identified with all these 4 symptoms. There are certain newer initiatives and good best practices followed by some of the ART centers where stamps are used so that the cases are not missed. You can see on the screen these 4 symptoms, positive or negative stamps are very well used, and the staff nurse records all the details specifically related to 4S. So any of these 4 symptoms, if we identify these patients, we can fast track these patients to the microscopic centers from the RNTCP. We have seen that all these microscopic centers are within the same facility of the ART centers. So basically you have to identify these 4 symptoms and then record all those things. We are also suggesting to record the different symptoms among the 4 symptoms, because with the newer diagnostic coming in, we have to see that all these symptoms are captured, and we want to know exactly how much patients are coming with what symptoms. So any of these 4 symptoms at the ART centers or the ICTCs should not be missed. Even in private settings we can follow these things, and community settings also we can follow these 4 symptom screening. Recently the National Technical Working Group also, based on the feedback from the field, took a decision that the care coordinators who are the first point of contact can also be they can also trigger the uh, symptom screening and record those things like 4S positive or 4S negative, because we don't want to miss any case when it comes to TB. And therefore the guidance tool for TB, strengthening the ICF at the ART centers, as you see on the picture, was developed and circulated, but we have to see that and ensure that this is utilized and the care coordinators know about these 4 symptoms. Even recently we have coordination with the care support centers, and they are very much involved in the TB and HIV collaborative activities. We have seen that community-based TB and HIV integration is very much inbuilt in the care support centers, and that's why the care support centers referring to the diagnostic centers through the different settings is very valuable, and we are in process of developing certain guidance to the care support centers also. We have seen recently that the care support centers, with the initial training and all those interventions, are now able to give an yield of almost 8% of TB cases, and the referral is very good and improving in these settings. So it is very important to percolate the knowledge about these things down the line, and each setting should know about the prioritizing TB symptom screening within their setup. It is very critical, as you see this slide by Chris Dye showing doctors and delays specifically in Bangalore. You can see on the left side that a TB patient, either he is a male or a female, the number of doctors visited by these patients are ranging from 1 to 7. So almost highest number of the patients are visiting 3 doctors at least before they come for the final diagnosis, and it takes too much of time for them to reach the government setting. So in this situation, you can understand the delays which are happening, and as the number of visit to different doctors increases, there is a extra delay. So each extra doctor seen by a TB suspect can add to 12 days delay. So you can see that in most of the government settings, we see that patients come with a very huge delay of diagnosis, and some patients come at a point where they are land into the drug-resistant TB or XDR like situation. So it is very important to engage all healthcare providers in public as well as private settings. Government of India has noticed the strengths of private sector, and we have in RNTCP very good strong coordination with the private sector. There are separate guidance and guidelines for the private sector engagement, the NGO engagement in RNTCP, and also in TB HIV. We have prioritized, as you see from the circular, we have prioritized intensified TB case finding as well as TB HIV collaborative activities in the private setting. So wherever there are DMCs or microscopic centers in the private settings, they can have option of screening HIV patients also, and contribute to TB and HIV collaborative activities. So we are reaching up to large number of private sector through the professional bodies, and they are also supporting us in this very good initiative. Government of India, specifically NACO, has also recently revised the involvement of private sector in HIV as with coming up with different models. So we have different models for engaging the private sector, and we see that the private sector is very much interested to join hands with the government to increase the not only the screening but also contribute to the TB and HIV activities. It is, as you see, sometimes it is very disturbing to see some low quality diagnosis, poor quality diagnosis in different parts. But it is very important and crucial now to provide patients with the quality of care as mentioned in the international standards of TB care and the standards for TB care in India. So we should ensure that standards of TB diagnosis are very much followed in each and every setting, whether it is a private setting or a public setting. So we have to ensure that patient gets a quality diagnosis, and there is no misdiagnosis and other poor quality diagnosis when it comes to patient related services. Now, what is crucial and what are the newer opportunities we see in these days is like the newer diagnosis, which and the newer technologies are going to help us to improve TB diagnosis, and definitely they are going to change the dynamics of TB diagnosis. If you see the time delays and other factors which are playing in misdiagnosis as well as patients out of pocket expenses, newer diagnoses have that potential to change the scenario, and it is very crucial to know about all these things. Government, if you see, has been now taking a lot of initiatives, not only in one or two sectors like the transportation and other sectors, IT sectors and other sectors, but also we are finding that we actually are embarking on the technology aspects which are giving us opportunity to build up smart diagnostic techniques and provide patient quality care as with a rapid diagnosis. So Government of India has introduced rapid diagnostics since 2009 with Line Probe SA, and now we have a better scale up of all those rapid diagnostic tools, which include Line Probe SA and CBNAAT, that is cartridge based nucleic acid amplification test, and there are a lot of other diagnostic improvements in drug resistant TB diagnosis, specifically the quality IRLs and the SRLs are increasing in gradually over the period of time. Cartridge based nucleic acid amplification test, which started initially at 18 sites, has now expanded to larger and broader countrywide scale up, and we have seen that from the 30 sites it has increased to 110, and now 300 additional sites have been provided for TB HIV collaborative activities and scale up our interventions to diagnose TB early among people living with HIV. These rapid molecular diagnostics, specifically as you see on your screen, a lot of studies related to cartridge based nucleic acid amplification test, you can see that the feasibility, diagnostic accuracy and effectiveness of the decentralized use of cartridge based nucleic acid amplification test is very much critical these days, and it is giving a very high yield specifically for the rifampicin resistant diagnosis, and it is an additional yield for all the people living with HIV screened through the CBNAAT. So Government of India has different policies, and we are prioritizing people living with HIV pediatric cases for use of CBNAAT in addition to the programmatic settings for the drug resistant TB and other settings. So now with the increase in testing coverage, we will be able to diagnose TB early at facilities where we have ART centers, and within the same facility we are providing within the same facility. That means it doesn't mean that at the ART centers, but in the same hospital setup we are providing this diagnostic facility, so that the patient doesn't have to visit any other facilities for TB diagnosis, and in that turn sometimes the cases are missed. So from NACO as well, from CST and BSD collaborative efforts, we have been using these CBNAAT services in some of these centers with the availability, and now we are scaling up. So based on the decision of the National Technical Working Group for use of CBNAAT, we are now expanding these services to almost 300 districts in a short span. In our field visits, we found that there were some knowledge gaps related to knowledge regarding the cartridge based nucleic acid amplification test. Sometimes it is also called in other settings as gene expert, but it is very critical to know about these newer diagnostic technologies. It is very simple equipment which is having modules and then cartridges, self-contained disposable cartridges, and attached computer and software with a barcode scanner for each cartridge, and printer and UPS for getting results and sending the report. So basically it is a very simplified system with a very high quality yield. And running of the CBNAAT test is also very simple, and you don't have to do a lot of technicalities in if the sample is processed later on. It is very easy to get the result by insertion of the cartridge in the CBNAAT equipment, and it will provide you with the result of TB sensitive or TB or rifampicin resistance, diagnosis of TB as well as rifampicin resistance within 90 minutes. So this is a landmark thing. Basically, when it comes to people who are coming from distant places, and when there is a delay in diagnosis of TB, they ideally are missed out, and they are missed on opportunities of getting diagnosed for TB as well as drug resistant TB. If you want to know more on this one, if you see this slide, you can see that these videos and details on the CBNAAT are available at the India HIV/AIDS Resource Center. You can follow the link and view the video of the CBNAAT practical test, and it is always better to visit the nearest ERT, visit the nearest center facility where the CBNAAT is there, and see a practical demo of all those things. So it is critical to know these things. Practically it is very easy, and as you see in the picture, it requires very less space and doesn't need a big lab or all. It has limited operational requirements, and it is operationally also very feasible. The best part is like it is a scalable model, and based on the workload we can increase the number of cartridges and the equipments subsequently. Recently there are certain demonstration sites where the CBNAAT with the different cartridges, this platform is the same, but there are different cartridges which will be helpful in diagnosis of hepatitis, cancer, and even viral load testing can also be done. So there are newer equipments which are coming up with more multi battery of test, and we can get multiple diagnoses from these. As you might be knowing, to address the intervention, to address the problem of mortality among people living with HIV due to TB, we have the 3I project in 30 ERT centers in 5 high burden states, which was launched last year on the World TB Day, where we are providing certain services like the single window services for TB and HIV, intensified case finding using CBNAAT, and there are a lot of other initiatives like airborne infection control and isoniazid preventive therapy will follow subsequently, and pharmacovigilance and other services which are compounded into this as a package in the 3I project, and it is yielding very good result when it comes to patient satisfaction, diagnosis and early initiation of treatment. So it is very critical now that we have to link all the people living with HIV for CBNAAT services wherever they are available, and it will be available in almost 300 districts in shortly. So we ideally there will be one district where we will have this facility in addition to the existing facilities where it is operationalized in more than 150 facilities. So this will be actually very critical for early diagnosis of TB among people living with HIV, and linking and referring these patients to the nearest CBNAAT site from the ART center is very critical. There is a simple form for this one. There will be a revision subsequently based on the technical operational guidelines of TB. Still, you can use this form where you can tick the people. You can tick exactly whatever diagnosis is needed using this form. This will be changed with the technical operational guidelines. There is a requirement of recording all those things, and we will not be able to assess the progress unless we record the things and report it properly. So basically we have revised certain format in all these 30 ART centers, and subsequently as and when we scale up these initiatives, we will be changing the formats for reporting the 3I the initiatives as per the scale up. It is very critical. If you see the 3B reporting format from the ART center, it is critical to note down how many patients are referred to CBNAAT services and how many of them were diagnosed with TB as well as rifampicin resistance. So in ICTCs also we have modified this accordingly, because we want to know how much screening is done for rifampicin resistance and drug resistant TB forms to link these patients to the subsequent MDR and XDR treatment. So it is not only important to report timely, but also to ensure that the reports are sent correctly with all these aspects into the not only diagnosing TB cases, but it will be very critical to actually link these patients to appropriate treatment, that is daily anti-TB treatment, as a single window or one-stop service, because patients should not be going to different places when it comes to seeking treatment. And as you have seen the slide in private sector, you can also see that a lot of patients can be missed, and there is significant delay if the patient is going to different setting to collect the treatment. And that's why Government of India has provided one-stop service for the patients, so that there is a feasibility for the patients, and there is no delay, which will significantly reduce the mortality also. It is also important to see that the patient is not missing the treatment. So in the 3I project, we have developed an innovative drug tracking mechanism, drug intake tracking mechanism, using an mobile application where a toll-free number is provided on the back strip of the strip, and the patient can dial to this number, and his entire treatment will be tracked, and there will be some SMS advisories sent to the patient if the patient is missing the doses. So in addition to the regular supervision and monitoring of the treatment adherence, we have also used technology to see that the patient is taking drugs properly. Ultimately, that only will lead to reduction in the mortality and subsequent transmission of TB. So single window means actually we have to provide services from the same hospital facility, from wherever the patient is availing the drug services. So patient does not actually travel to different places to get the treatment. To know more on the TB HIV collaborative activities, it is very critical to go through the different trainings, and we have developed an integrated training module for HIV and TB. For daily regimen and anti-TB, we will be conducting training session in the last week for all the ART center, important ART center faculties, and even we have developed an e-learning module for TB and HIV, which will be going across to all the health providers who are interested to know about TB and HIV. So there are a lot of platforms where you can know about TB and HIV collaborative activities, what are the different modalities for infection control, intensified case finding for TB, and also details on various aspects of TB HIV collaboration. So I request you to go through these documents which are available on NACO's India HIV/AIDS Resource Center, as well as NACO's webpage, publications specifically related to HIV and TB. So you can get all these documents. It is now our social responsibility, as well as important priority, to diagnose TB early and to get cured from TB as early as possible. You can see a lot of celebrities endorsing these TB HIV initiatives, and we saw that a lot of global partners and national administrative as well as political commitment was seen for TB Mukt Bharat, and we have to join hands for that. Then only we can defeat TB. That means TB harega or Desh jitega. Thank you very much for patient listening. You can always refer to the documents for details. This was a short presentation for intensified TB case finding on TB and HIV. I thank ITech for giving me this opportunity to have an interaction with you. Thank you very much.
Thank you so much for your valuable session, sir, and your valuable time as well. And then I'm requesting all the participants to kindly enter a e-poll, so which is like displaying on the screen. So once again, I'm requesting all the participants to kindly enter a e-poll. Thank you. And then the recorded link and then the presentations will be shared with all the participants shortly. Thank you. Thank you for attending this session.